Welcome, everyone, to our first lecture on primary health care as a means of reaching health for all. The title of this lecture is called Primary Health Care in Developing Countries, Origins, Principles, and Evolution. This lecture was originally recorded for a course I teach here at the Johns Hopkins School of Public Health called Introduction to International Health. And so there will be several points in the lecture, particularly at the beginning, where it will be obvious that this was recorded initially for another purpose. But the first lecture that you'll be hearing today is a portion of a larger lecture that this recording is taken from. And then next week, we will be listening to another portion of this lecture for the first half of next week's lecture, and then the second half of that will be a recording that Carl Taylor made before his death about the origins of primary health care. I'm very pleased to be sharing all this information with you. It's of deep value to me personally, and so the opportunity to share these important historical experiences and ideas and principles are a great privilege for me, so welcome. As you know, I'm relatively new to Johns Hopkins. I've been on the faculty since 2009, and my own career evolution started out first as an MPH student here in the early 1970s, and then I trained in general surgery, and during my residency training, I had the opportunity to visit the Hospital Albert Schweitzer in Haiti. I worked in Bolivia in the early 1980s, starting a community health program, and I was doing surgery as well during that time. I spent 10 years living in the mountains of North Carolina, practicing surgery and also providing leadership to a small NGO that I started called Cure Americas, originally Andean Rural Healthcare, and I'll be mentioning a little bit about that. And then in the middle 1990s, I had the great privilege of moving to Bangladesh and working with Johns Hopkins on a project there at the International Center for Diarrheal Disease Research, and later with the BASICS project concerned with child survival in Bangladesh. And so I'll be referring to some of my experiences there in Bangladesh. And then following that, I had the great honor of serving as the director of the Hospital Albert Schweitzer in Haiti, which I had first visited quite a few years earlier, and I'll be speaking a little bit about that. Starting in 2000, I spent a number of years working with Future Generations, which is an NGO that Carl Taylor started along with his son, and I'll be mentioning some of that as well. As we go through this, I'll be talking off and on about Carl Taylor, who founded our Department of International Health here in the early 1960s and was a passionate proponent of primary health care and, in fact, a global leader of primary health care. So we'll get into that in just a minute, but it's a recurring theme through all of this. Carl always felt that John B. Grant was the father of primary health care. John Grant was a very distinguished physician who worked with the Rockefeller Foundation in a number of countries, but his most important contribution was his work in China back in the 1930s. And at that time, he worked with some of the very well-known Chinese people concerned with improving the welfare of rural China, most notably Jenny Yin and C.C. Chin. And through that project, gained a lot of experience that was very influential in the development of primary health care. He wrote this book, which Carl always referred to as the Bible of primary health care, published by the Johns Hopkins Press in 1963, called Healthcare for the Community. But in that book, he really repeatedly talks about how the community can and should be linked to health systems, and how health is an integral part of development, and how training and research need to be built into all of these activities in order to make real solid progress. This general philosophical approach is reflected in this statement from John Grant's book. in which he talks about the need to demonstrate feasibility and worth in projects and programs, and to make use of technical methods which are scientifically efficient and economically practical, and the need to integrate programs horizontally rather than working in narrow single activities. This was written back in 1934, and the themes that he touches on here continue to resonate as being important ones for us to consider. The project that John Grant helped Jimmy Yin and C.C. Chen develop was called Ding Xin. It was 100 miles from Beijing. At that time, China was among the poorest countries in the world, and in the rural parts of China, certainly conditions were among the very worst in the world. And resources were extremely scarce, and health facilities, health professionals were extremely scarce as well. And so in the midst of that context, these three people developed some ideas that seemed kind of simple, but still they were very profound and had an enormous influence. The first thing they did was they conducted surveys to identify what the health problems really were. And then they trained local people, non-healthcare professionals, people with no formal training or formal background in health, to begin to be engaged in important and priority healthcare activities. They got them engaged in recording vital events, vaccination against smallpox, administering simple treatments, giving basic health education, and maintaining wells. And these farmer scholars, as they call them, became the forerunner of the Barefoot Doctor program, which later became so famous. But that experience was also an important model for what later became China's rural transformation and development. This is all explained in some detail in this wonderful book that Carl Taylor and his son Daniel wrote called Just and Lasting Change, which I'll get to in just a minute. Carl Taylor's mentor when he was a student at Harvard was a very outstanding man named John Gordon, who actually worked in China with John Grant. So the personal connections of these people and the ideas that they promoted and built upon, one leading to another, are an interesting part of the primary healthcare story. John Gordon, in his own work prior to that time, had been involved in some work in Romania with the Rockefeller Foundation, and he had on his own developed the concept of routine systematic home visitation as a way of providing surveillance data, and he was the first person to record an epidemic from the very first case to the very last case. This was an epidemic of rheumatic fever that he was all set up to capture. And through that experience, as well as others, he became aware that home visitation had some real power to it from the public health standpoint. And I'll be referring to some of this as we move along. But when Carl Taylor studied at Harvard Medical School and then later at the School of Public Health, he took classes in epidemiology from John Gordon, and John Gordon taught a course in project development, and he served as Carl's mentor in the development of some very important ideas that we'll be referring to. Also, you see that John Gordon was the mentor of John Wyan, who was a friend of Carl's in India back in the 50s, and John as well fits into this story in a number of different ways, and I'll get to that in a minute. Two of the towering figures in primary health care are Halfdan Mahler and James Grant. Halfdan Mahler is still living. James Grant died several years ago now. But both were extremely dynamic and charismatic people. James Grant was John Grant's son, interestingly enough, and he had grown up in China and had quite an international experience prior to growing up, and spoke fluent Chinese and so forth, and so had quite a background for this role. He was not a physician, but had worked in development programs in had quite a senior career in various development activities before becoming executive director of UNICEF. Halfdan Mahler had been a medical missionary in India working in tuberculosis. He is Danish, and he was a friend of Carl Taylor's back in those early days in India. But both of these people had long tenures at their respective organizations, and I think both are considered to be the most outstanding directors of these organizations that they've ever had, and this was an important part of the evolution of primary health care that we'll get into in a minute. Let me just mention a few words about Carl and his unusual background as well as his enormous contributions. Here you see him as a adolescent, I presume, in India when he was growing up, and on the right you see him about 2 years before he died when he had received an honorary doctorate from Johns Hopkins University. His career in international health spanned from age 7 to age 93. So I think the math says that that's about 86 years. Extraordinary career. He has had these accolades from very high-powered people. John Rhodey, who was James Grant's special assistant for 15 years, considers him to be the acknowledged leader of primary care over the second half of the 20th century. And Halfdan Mahler was quoted in the New York Times after Carl Taylor died as saying that he's the greatest public health expert I have come across. So he's somebody that Johns Hopkins takes great pride in claiming, although, of course, he spent a large part of his life in other places before coming to Hopkins, but still he started the Department of International Health here, and many people consider that he is the founder of the whole field of international health, not to mention primary health care. So his contributions are enormous. But here we want to focus on his own work in primary health care. In this slide, you see Carl Taylor's mother and father. They were both medical doctors, and they were missionaries in northern India and the Punjab, and they spent most of their time traveling from village to village, treating people and their illnesses. Here you see on the left Carl's father, John, treating the men, and his mother, Elizabeth, treating the women. And they would spend their days engaged in this kind of work. They had had the opportunity to work in a hospital when they first went out there, but they later decided that they needed to get out to the village where the people were and to really understand and respond to the problems on the ground. And this has important implications in Carl's development, as we'll see in a minute. Here you see the kind of peripatetic life that they would lead. They would go around in these ox carts with all their things and go from village to village. Here you see, in the bottom left, you see Carl as a young child with his brother and their pet anteater. And here in the next slide, you see Carl with the rest of his family in native Indian garb. So it's a classic missionary family that's gone native, you might say, but they were very much ingrained in the local life there. And after Carl finished medical school, he went back to this same area as a medical missionary with the Presbyterian Church. And soon after his arrival back there, Indian independence came, and there was partition between India and Pakistan, and there were massive riots and enormous bloodshed and enormous loss of life. And he got engaged in responding to that and got his career started in a very dramatic fashion. But several years later, he got involved in developing some interesting projects in northern India and the Punjab where he had grown up. He worked with the Ludhiana Medical College, and they started some projects to train local doctors to work in rural areas. But another important project they got involved with was something called the Kana study. And here you see Carl Taylor in shorts looking towards us, and standing next to him to our left is a tall man named John Wyan, who had also gone out to India as a medical missionary and became friends with Curl, and they had a similar interest in community health and what was going on in the villages. I'll get back to that in just a second. So here you see the location of Narangwal near Ludhiana, where the Narangwal project was, and it's near where the Kana project was. The Narangwal project was Curl's major activity during his early years, and he had started on that before he came to Hopkins as chair of the department. And for the first 10 years or so that he was at Hopkins, it was the dominant activity in the Department of International Health. But it was a pioneering primary health care project that had quite a bit of community-based activities that took place outside of facilities involving community health workers and home visitations and so forth, as you can see in these slides. But another interesting part of this is that it was a very high-powered research project with various experimental cells in which villages were assigned to different kinds of groups for different kinds of activities. And they had a very high level of engagement of the Ministry of Health in these activities. And once a year, the project would bring in the Ministry of Health and other high-level officials from Delhi to review the findings of the Narangwal project and discuss their implications for healthcare services more broadly in India. And here in this next slide, you see Curl, the very dashing man there with the tie on, having a reception for these officials at his home in the village in Narangwal. There are lots of interesting things about the Narangwal project that I don't have time to tell you about. A summary of the project is in 2 volumes published by the World Bank here back in the early 80s. But one of the interesting aspects of it is that the staff lived in the village, mixed and mingled among all the other households. There wasn't like a separate compound, and so this whole project was integrated into the life of the village, and it had a very important impact on the way the project moved forward. There was a very strong participation of the community in the research project and discussion of the findings with the community as well as with higher-level officials, too. But this project was an important foundation for the 1978 Alma-Ata conference. In addition to the Narangwal project, however, there was a growing recognition that the international health work up until that time was becoming misguided. And the reason I say that is because Christian medical missions were very hospital-focused, and people were realizing that these hospitals themselves weren't really responding to the major health needs of the people. There was an organization called the Christian Medical Commission that was formed that had its office in Geneva. And they did a study in which they went around the world and they looked at the health of the people who lived close to a mission hospital, and they compared it to health of people who lived further away from the hospital, and they concluded that there was no difference in the health of people who lived closer to a hospital than people who lived further away. And so that caused some serious thinking about what was being accomplished by these very prestigious hospitals that focused on curative care, mostly for adults. That whole experience of the Christian Medical Commission had an important influence, as I'll mention in a minute, on the evolution of thinking at WHO. In addition to the work of the Christian Medical Commission, the World Health Organization sponsored the publication of a book called Health by the People, and it was very clear from that book and the examples of community health care from various places around the world that a whole new approach was needed. And that book certainly pointed out the fact that the medical model of curative care was not going to really be the answer to the health needs of the population. And much of this was hospital-focused. So with that kind of background and Carl Taylor's close relationship to Halfdan Mahler that went way back to their time in India, Halfdan Mahler asked Carl Taylor to be his special envoy and he played a key role in the development of what became the International Conference on Primary Health Care in 1978, held at Alma-Ata. At that time it was USSR, now in Kazakhstan. And Carl told me that during those years he was going back and forth to Geneva like a yo-yo, but he spent an enormous amount of time on that. So one of the interesting things that happened is that the people working with the Christian Medical Commission in Geneva started talking to the high-level people at WHO, and Halfdan Mahler, having come from a Christian medical missions background, he knew these people and he saw the value of what they were doing. And so that relationship led to quite a strong influence at WHO, as described in this article in the American Journal of Public Health in 2004. Here you see the contents of this book called Health by the People, which was published in 1975, which was an important foundation for the International Conference on Primary Health Care. And you see the discussion of the barefoot doctor concept in China is the first chapter in this book. But perhaps the most important chapter in this book was the one written by Mabel and Arole, you see on page 7, describing the JOMKED project. The Aroles were students of Carl Taylor's and went to this very deprived area of central India and started a project that within 4 or 5 years had become world famous, and we'll get into that a little bit more. But so much of what happened at Alma-Ata, I think, was strongly influenced by what the Aroles did. Here you see a photograph of the meeting itself, very much Soviet-style type of setting, obviously. The International Conference on Primary Health Care that was held at Alma-Ata in September of 1978 was the most important global health conference that had been held in the world up until that time. It was attended by leading health figures from all over the world, and they focused on this very important idea of what primary health care is and what it should be, what it might be. And the outcome of this conference, which is so important for our course and so important historically, is the declaration that was unanimously approved by everyone. We refer to this as the Declaration of Alma-Ata. The declaration is only 2 pages long, and it's available on the internet, and you have it in your readings. But what makes it special in many different ways is, first of all, how well written it is and how incredibly concise but still profound the ideas of primary health care are that can be seen in this document. And we're going to be talking in the next lecture next week on what exactly is in this, and you'll be reading it yourself as part of the readings for the course. But just to give you a few ideas about why this is so important is that, first of all, the concepts of primary health care that are described in the declaration are very different from the idea of primary medical care in the developed world. So for much of the world, and particularly for scientific experts and so forth, the notions here were very different from traditional medical notions. And as I have said and will continue to say, it very much focuses on what might be considered as first principles, the very basic conditions that are needed within society to achieve health, whether they're medical care, treatment, or other so-called social determinants of health. And as a result, it was not received very favorably by the more traditional medical scientific establishment, and many considered it to be a radical attack on the medical establishment as well. But in fact, if you read and think about what's in the Declaration, I don't think that's true. But because it incorporated new ideas that went far beyond simply the practice of medicine by doctors, it wasn't warmly received by everyone once it became known and discussed and was widely publicized following the International Conference on Primary Health Care. When The Lancet published its series on Alma-Ata in 2008, which was celebrating the 30 years following the conference, Margaret Chan, who was the Director General of the World Health Organization, she made this statement in an editorial that preceded the document, which I think does a great job of focusing in on some of the key values that are embedded in the Declaration of Alma-Ata. She said that it honors the resilience and ingenuity of the human spirit and made space for solutions created by communities, owned by them, and sustained by them. And so obviously you can see just from this that this approach to primary health care goes far beyond the traditional medical model. I wanted to share with you this statement that came from Maybell and Roger Arole in their book called Jamked, which is one of the great classics of global health and primary health care. And so if you've never heard of it and really want to get into this whole idea of primary health care in a deeper way, I strongly urge you to obtain this book by the Aroles called Jamked: A Comprehensive Primary Health Care Program. This sentence that you see on your screen here, again, gives a sense of what the Declaration of Alma-Ata is trying to get at. Again, it promotes this idea of working with local people, using the capabilities that local people have to engage with them and to enable them to take responsibility for and to take action to improve their health. Again, very different approach from the traditional medical model of curative care provided by highly trained physicians. And so even though this statement is not actually in the Declaration of Alma-Ata, I think it gives a good sense of, I think, the deeper meaning of the Declaration of Alma-Ata. He goes on to say that, and again, this reflects the challenge to the medical model. He talks about the need to demystify medicine and to share knowledge freely with people so that they can attain and maintain good health. Hierarchical attitudes, which unfortunately are a dominant part of the medical model, less so now, but certainly part of the history of medicine. Hierarchical attitudes have to be replaced by team spirit and equality, the realization that knowledge not only gives power, but that sharing knowledge also increases self-esteem is important in the development of a team spirit. So these philosophical elements are very much embedded in the whole notion of Alma-Ata. Unfortunately, after the International Conference on Primary Health Care in 1978 and the enormous enthusiasm that was created, the whole movement underwent a rapid decline. It's a very important part of the history of global health to look at this and to think about it. And exactly why these things took place is also a fascinating question which people like to think about, and I'm not sure the final answer has been written on that. But for many people, the whole notion of health for all by the year 2000, which the Declaration at Alma-Ata called for, was too broad and idealistic with an unrealistic timetable. And at that same time as well, the importance of immunizations was being recognized, and the low coverage of immunization services in developing countries was becoming a problem. In the early 80s, the coverage of immunizations in most poor countries was only 5 to 10%. And so people, expert authorities like D.A. Henderson, the former dean here, who was the leader of the smallpox eradication program at WHO, began to push for an expanded program on immunization, EPI. And also at that time as well, oral rehydration solution had been developed as a very simple way to treat dehydration caused by diarrhea. And so these twin engines became very much the favored approach of global health experts who weren't in the same philosophical tradition of Alma-Ata, and they began promoting this, and this became the beginning of what we call today the selective primary health care approach, vertical programs which have many different characteristics from what was envisioned at Alma-Ata. But this later merged into what was back in the 80s called GOBI-FFF, growth monitoring, oral rehydration, breastfeeding, immunizations, food supplementation, female literacy, and family planning. It was sort of the extension of a very narrow but still highly selective vertical approach. There were lots of reasons why the selective approach became so much more powerful than the Alma-Ata approach. Julia Walsh and Kenneth Warren wrote this very famous article in the New England Journal of Medicine in 1979, arguing for the cost-effectiveness of the selective approach to primary health care. And they made it very clear in their article that they saw this not the long-term answer, but as a short-term interim strategy for disease control. And I think we're finally beginning to move out of this interim strategy and towards a more comprehensive approach, but there's still a lot of debate about these two approaches, and I'll get into this a little bit further. We come back here to James Grant, who became the global proponent for the selective approach, interestingly enough, and UNICEF, with its resources and prestige, was the dynamic force that led to the expansion of programs, particularly for oral rehydration therapy and for immunizations. And James Grant was very famous for traveling all around the world, meeting with heads of state, and he would always pull out his oral rehydration salts packet and promote ORT and immunizations. John Rohde was his right-hand man, a very competent Harvard-trained pediatrician who saw the power of the selective approach, and they worked hand in hand on this. But Carl Taylor liked to remind James Grant that his own father, John Grant, would not approve of what he was doing because his father had a much more holistic approach, as that initial statement indicated that I talked about at the start of the lecture. Other reasons for the rapid loss of momentum of the Health for All movement, as many people call the Alma-Ata concepts, was the weak leadership at WHO globally, and also weak leadership at the country level in WHO, and the medical orientation of what many people refer to as the World Disease Organization rather than the World Health Organization. But there was also lack of strong scientific evidence of the progress that could be achieved with the broader approaches, and there was strong scientific achievements that could be shown for oral rehydration therapy and immunizations. So the scientific part of this was an issue. And then there were the politics that fed in this as well. And many people considered Health for All to be a part of the leftist, socialist, communist agenda. And so that didn't help obtaining support from it from the West, and particularly the United States. And so we have this ongoing tension that's still with us today after 3 decades, more than 3 decades, between the approach of what many people refer to as a more horizontal approach, integrated approach, grassroots approach that works with the felt needs of people and provides a broader scope of services, as opposed to a highly selective, top-down, externally funded approach that's focused on highly targeted but still epidemiological important conditions and diseases. But tied in with these two approaches are also some themes that permeate global health more broadly, but particularly in the primary health care area as well. And that is the reality that health problems are, and particularly in the very poor countries of our world today, are still very much a product of the social and economic conditions of people. And so creating a longer-term, sustained, improved response to health conditions requires addressing the social and economic determinants of health, and that requires a political response in order to make a real difference in the health in the longer term. But at the same time, we recognize that very dramatic things can be done with very simple and inexpensive technical or biomedical interventions, such as the administration of vitamin A, a pill that you only need to take every 6 months, and it reduces the mortality rates of children by a third. So how can we not be engaged as public health professionals in promoting these simple, low-cost interventions as well? And so this dilemma continues with us, as I said. The major funding programs today are very much disease-focused. The Global Fund to fight AIDS, tuberculosis, and malaria, PEPFAR, the President's Emergency Program for AIDS Relief, the President's Malaria Initiative are all reflections of this top-down vertical approach that are extensions of GOBI and the earlier highly selective approaches. But at the same time, the inability of these very narrow approaches to build up health systems and to build sustainable integrated programs is also becoming recognized. And so we're entering a new phase in which there's a broad agreement that we need to be putting more emphasis on horizontal integrated systems approaches, and also the need to engage communities and build them in as partners in this process as well. So some people like to say that we have all become diagonalists now. Jaime Sepulveda, high-level researcher and policy advocate from Mexico, who more recently has been working with the Gates Foundation, has made this statement very powerfully in one of his Lancet articles about we need to have both. People recognize that, of course, the vertical approach is valuable, but we also need the horizontal approach, and they shouldn't be seen as competitors, but as complementary. Unfortunately, over this history after Alma-Ata, the vertical approach was so dominant that the horizontal approach was sort of left behind. So we're now in a phase of building up the horizontal approach. The World Health Report in 2008 was focused on primary health care, and they mentioned some important issues that have detracted away from primary health care. One is what they call hospital centrism. So this early idea of that I mentioned with the Christian Medical Commission of needing to get away from hospitals, or I should restate that it's not the need to get away from hospitals, but it's the need to get away from having hospitals as the center of health program activities. And by the center, I mean where most of the money is going, among other things. That's been a major detractor for developing primary health care services, because the political pressure and the people making decisions about funds have given priority to hospital services and the high technology that goes along with them. And in addition to the hospital centrism, this report focused on the problems of commercialization and fragmentation as being detractors towards the full development of primary health care as we know it. And as a result of these forces that lead away from primary health care, we have problems today with health equity, lack of access to care, and very unhealthy communities. John Grant referred to public health in this quotation that you see above here, but it's got a strong relationship to primary health care. Public health is the science and art of social utilization of scientific knowledge for medical protection by maintaining health, preventing disease, and curing disease through organized community efforts. So it's those organized community efforts that are such a fundamental part of primary health care, which again focus on the non-medical model of primary health care. And in this vein, I wanted to mention some concepts that I learned from John Wyan, who I had the privilege of working with for a long time in my early career. John always referred to three kinds of public health: disease-oriented public health, service-oriented public health, and community-oriented public health. And this is where primary health care and public health become linked, at least in my mind. We know that disease-oriented public health is focused on reducing the effect of a disease in a population. Services-oriented public health works to get basic services out to a population, which I guess is a part of primary health care, perhaps, as long as those services are not hospital services. But community-oriented public health is focused on a practitioner of public health working with a community or a set of communities to help that community improve its health. And unfortunately, community-oriented public health and the primary health care notion that's linked into it is very underdeveloped in academic public health, and it's very underdeveloped in global health more broadly. John always used to like to say that these three types of public health are like the three legs of a three-legged stool, and they each complement each other, and with one of the legs being weak, the platform of the stool is weak as well, no matter how strong the other legs might be. So I've been going in some detail into all of this history and some of the issues involved in the development of primary health care. Let's take a break, and when we come back, we'll continue this discussion, but bring it into a more current context.